Mexican. My pronouns she and her. I am I'm speaking to you from the uh, 3D13 uh, territory today. And just to give you my description, I'm a woman with short curly hair, uh, brown complexion, and wearing a white cardigan. I'm extremely happy to be here today to introduce this webinar on a topic that is so important and very, very close to my heart as a mom who has a disability and is mother to a 22-year-old son. Um, I am sure you will learn today that this study has filled some important gaps in pregnancy related healthcare and its intersection with disability. I really wish when I became a mother in early 2000, a study like this has been done and some of the findings were implemented so that I could have a little bit stress-free pregnancy and enjoy my journey to motherhood a little bit more than trying to advocate for myself. As you read through the reports, you can see that the families with disabilities report unmet pregnancy care needs, even though statistically they experience more complicated health conditions and require more hospital needs. We know that through the report, people with disabilities identified communication as an accessibility barrier in healthcare setting, as well as poor knowledge about disabilities, lack of training on disabilities, and ableist assumptions from healthcare providers. So if I could give you one very quick example of my experience as a 35-year-old woman when I got pregnant, I thought I have taken a lot of precautions in preparing myself. So I am financially prepared. My home is ready to have a new baby in place. So safety and at individual level, I have done everything in my power to make sure that I'm able, ready, and willing to be a mother with a full-time career and a spinal cord injury. However, when I entered through the pregnancy, without even knowing the nature of my disabilities, I was placed in a high-risk pregnancy clinic, which was far away from my residence, my place of residence. So that put an extra burden of me finding, me trying to, find time to enter into the premises of the hospital and drive a long ways to get my um, weekly, monthly meetings done. And on top of that, I realized this hospital, even though it was a high risk care clinic, it was not ready to have a woman with disability as part of their care provisions, and we struggled. They didn't understand that having a disability does not automatically put me through put me into a high risk pregnancy, and I didn't understand that the little processes that were in place for other women with disabilities, why I did not have access to those. For example, weighing on my weekly meetings to just demonstrate that my baby is growing, healthy. That was not a provision that's available to me. So that, it was always a assumption on their part that if the baby is healthy, the growth is healthy. My morning sickness, which lasted for 9 months. Nobody was there to tell me that that's a normal part of pregnancy in some cases. It doesn't go away for every woman. It doesn't go away after 12 months, 12 weeks. So, all those uninformed decisions that I have to make during my pregnancy put an undue hardship on me, trying to find answers through my rehab doctor, who was not supposed to be, part of this care, because at the moment I was looking for a pediatric, not pediatric, but a uh, healthcare practitioner who can help me through my pregnancy. So anyhow, that's one example that I end up getting extremely sick after 6 months because this stress was not helping. I have no knowledge if my pregnancy was a healthy one. And on top of that, simple questions, how would I feel the pains, labor pains, and how would they manage me having no sensation and carrying a no sensation in my lower body and still carrying through a pregnancy? Would they have any provision to make up for that, limitation that I have? I did not get any answers. So just a small example that a time that was supposed to be very pleasant, which was supposed to be an enjoyable time of my pregnancy, it kind of was limited because the medical professionals were not there to really look at me as a woman with disabilities and provide me the care that I needed. So at the moment, we know the AODA, which is an act and has associated regulations that somewhat addresses some of the gaps in customer service or built environment, among other topics, is helping to advance accessibility. And specific regulation on information and communication standards also ensure that the communications with persons with disabilities as a client are equitable and inclusive. As a society, we have some way to go in a mindset change. We have to shift attitudes and perceptions that disabilities does not devalue a person. Accommodation is not always expensive. It is just making intentional provisions that we have accommodations to accommodate individuals based on their diverse need, whether they have a disability or not. Evidence and abundability is available that people with disabilities can deliver without any complications, as long as the systems are in place that they value people with disabilities and provide the care that they need. So with AODA, this is something we are striving to overcome, but there's more education needed. So that's why I'm really, really excited that, as stated in report, 1 in 8 pregnancies in Ontario are currently to the females with a disability. So this affects this population at such a large scale. And it is extremely important that we address the issue outlined in this research. So congratulations to the researcher, and I am going to pass it to our host. Thank you.
Thank you very much, Minu, for that wonderful start to our webinar today. My name is Hilary Brown. I'm an associate professor at the University of Toronto and adjunct scientist at ICES. And along with Dr. Yona Lunsky, I'm the co-lead on the disability and pregnancy study. So I'm just going to take a second and share my screen. And I'd just like to begin today by doing a brief land acknowledgement. I recognize that we're all coming to this webinar from different locations. I'm in Toronto, so I'll be using our land acknowledgement for the University of Toronto. So we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. So a brief overview of today's agenda. We already heard opening remarks from Minu Sikan, so thank you again, Minu, for this. I'll be spending the next few minutes giving you an overview of the findings and recommendations from the disability and pregnancy study, which was the basis for our report on the pregnancy outcomes and healthcare experiences of people with disabilities in Ontario, which was recently published through ICES. I'll then be turning it over to Dr. Anne Burndle to give us an example of what equity and inclusion in pregnancy care can look like through her Accessible Care Pregnancy Clinic, which is here in Toronto. We'll then have a panel discussion moderated by Yona, including members of our advisory committee from our study. We'll open it up for some questions and answers from the audience, and then Yona will close things off with some closing remarks. So equity and inclusion in pregnancy care, again, these are findings on our report on pregnancy outcomes and healthcare experiences of people with disabilities in Ontario. About 15 to 20% of the reproductive age population have a physical disability impacting mobility, sensory disability impacting hearing or vision, or developmental disability impacting cognition or adaptive skills. In 2005, the World Health Organization released a landmark report calling for better reproductive health care for people with disabilities. And the following year was the year in which the United Nations Convention on the Rights of Persons with Disabilities was published. And it too includes language around protecting reproductive and parenting rights for people with disabilities. However, almost 20 years later, we still hear often that people with disabilities feel that they continue to be underserved in reproductive healthcare settings. And so this was really the rationale for the research that we conducted with the disability and pregnancy study. We had a number of specific objectives. We aimed to describe the preconception, pregnancy, labor and birth, as well as postpartum and newborn health outcomes of people with disabilities in Ontario using population-based data. We also wanted to highlight the pregnancy care experiences of people with disabilities using qualitative data from the perspective of people with disabilities, as well as service providers and decision makers. And finally, we wanted to bring all of this data together to provide policy and clinical recommendations to improve pregnancy care for people with disabilities. And so this work was really a community engaged effort. We did this in collaboration with a large advisory committee that included people with lived experience of disability, service providers, as well as decision makers. We also worked in partnership with two researchers, peer researchers with lived experience of disability. And there were also a number of really brilliant postdoctoral fellows and trainees who were involved in generating the data for this research. And so you can see their smiling faces at the bottom of my screen here. And so there was a lot of effort and passion behind the scenes with this group of people that was put into this work. So I'm just going to provide a brief overview of our study methods, and you can refer to our report if you have detailed questions. In order to understand the pregnancy outcomes of people with disabilities, we used population-based data from ICES, which is our provincial data repository for all health administrative data in the province, and it includes linked data on all outpatient visits, ED visits, and hospital admissions for residents of the province. So we used this information to identify all 15 to 49-year-old females in Ontario, and we generated a cross-sectional population of over 500,000 reproductive age females with disabilities, and then a longitudinal cohort of about 150,000 births to females with disabilities between 2010 and 2019. And also included were comparison groups of people without known disabilities in the province as well. Then in order to understand the pregnancy experiences of people with disabilities, under the leadership of our former postdoctoral fellow, Dr. Leslie Tarasoff, we conducted qualitative interviews in partnership with peer research peer researchers with disabilities to speak with 31 people with disabilities and 31 service providers and decision makers about pregnancy care experiences of people with disabilities in Ontario. So I'm going to give you a really high-level overview of our findings, starting with preconception health. So we found that using our population-based data, about 16% of reproductive age females in Ontario had a physical disability, so things like multiple sclerosis, cerebral palsy, or spinal cord injuries, sensory disabilities like hearing or vision loss, and developmental disabilities like autism spectrum disorder, fetal alcohol spectrum disorder, or intellectual disability. We saw that in the preconception period, those with disabilities had an elevated risk of experiencing social determinants of health, such as poverty. And although most individuals entered pregnancy in a healthy state, there were increased risks of preconception health disparities in people with disabilities, including chronic health conditions like diabetes and mental health conditions like depression. But like Minu alluded to in her opening remarks, one of our most important findings was actually that 1 in 8 of pregnancies in Ontario are to a person with a documented physical, sensory, or developmental disability. So this is a really substantial proportion of the obstetric population, and is certainly provides us with evidence to really argue for the need for more accessible and equitable pregnancy care. So next, we looked at pregnancy outcomes, starting with receipt of prenatal care visits. And we saw that most people in Ontario, regardless of their disability status, had an adequate number of prenatal care visits, as recommended by the Society of Obstetricians and Gynecologists of Canada guidelines. And most people with and without disabilities were healthy during pregnancy. However, we did see disparities for people with disabilities in terms of rates of emergency department visits and hospital admissions during pregnancy, rare but serious physical health complications such as bleeding during pregnancy, mental health conditions, and other outcomes such as emergency department visits for interpersonal violence. Looking at labor and birth outcomes, there weren't many differences between groups with and without disabilities in terms of their rates of cesarean section or labor induction. However, people with disabilities, and especially those with developmental or multiple disabilities, were more likely to have a baby that was born preterm or small for gestational age. And on average, people with disabilities and their newborns stayed in hospital after the birth for longer than those without disabilities. During the birth hospital admission, we also saw reduced access to breastfeeding initiation and support in people with developmental as well as multiple disabilities. And then finally, for our postpartum and newborn outcomes, again, looking at the quantity of care received, most people with and without disabilities in the province received standard postpartum care visits. However, like during the prenatal period, in the postpartum period, people with disabilities did have slightly elevated rates of emergency department visits and hospital admissions, rare but serious physical health complications, mental health conditions, as well as emergency department visits for interpersonal violence. And their newborns were more likely to require a hospital admission in the first month as well. So population-based data are really helpful in terms of identifying population-level disparities, which can give us clues that something needs to be done to make care better. However, they don't tell us why these disparities exist or what we can do to address them. And so this is really why our qualitative data were so important for this project. So when we interviewed people with disabilities as well as service providers and decision makers, we grouped our findings into challenges and facilitators of good, accessible pregnancy care. And so I'm going to give a brief overview of both of these sort of sides of the story. So when we interviewed people with disabilities, some of the challenges we heard about related to the physical inaccessibility of healthcare spaces, as well as communication barriers with providers. So for example, a lack of ASL interpretation when that was needed. We also heard stories about fragmented care between multiple healthcare providers. So for example, different specialists involved in an individual's care. We heard some stories about people who felt that their providers did not have adequate training or knowledge related to disability. And unfortunately, we did hear some stories as well of a lack of respect and sometimes ableism from providers in their interactions with people with disabilities as well. Overall, one of the largest challenges that we heard about was just a real lack of information about disability and pregnancy, and people really felt that this affected their ability to autonomously make decisions. We did hear a lot of positive stories as well. We heard stories about advocacy from service providers, as well as family and friends, and even self-advocacy that made a big difference in people's pregnancy care experiences. We heard stories of providers who were very flexible in their care strategies, so things like services that were offered at home, and adapted and hands-on help, so adapted breastfeeding strategies and newborn care strategies, for example. We heard a lot of the same types of challenges and facilitators from service providers and decision makers. Many service providers spoke to us about how Ontario's fee-for-service remuneration policies really limited the way in which they could provide comprehensive care. So they were only remunerated a set amount for a certain amount of, or a set amount of time in terms of pregnancy care visits. And if they needed to provide more time to patients, that time was not remunerated. So that was a real challenge that was identified. Most of the service providers we talked to had not received any education or training about disability and had to seek that information out themselves. So that was a real challenge. And individuals also identified limited resources to support their delivery of care. On the positive side, a lot of service providers themselves had taken on advocacy roles to try to change policies to improve access. They also spoke about the advocacy they felt was important in the one-on-one relationships with their patients. So, for example, advocating for access needs like ASL interpreters. They spoke about the need to have holistic care that addresses not just medical, but also social needs more broadly. And they also talked about the importance of tailored care that meets their patients' unique needs. So we have a number of really, rich quotes that we have throughout our report, and I hope you'll take the time to read through it. Of course, today during our webinar, I don't have time to provide quotes for each of these themes that we identified. So instead, I want to provide a case example from a participant whose details have been anonymized, but this, I think, is a really important example of how some of these challenges and facilitators really shone through in the stories that we heard from participants. So this is the example of Siobhan. So Siobhan is a blind woman who lives in a suburban region with her children and husband. Siobhan sadly lost one of her babies due to a heart defect, and this loss substantially shaped her most recent pregnancy care experience. For her previous pregnancies, Siobhan's husband assisted her with taking pregnancy tests by reading the instructions and the results because the tests are site dependent. However, in her most recent pregnancy, Siobhan wanted to take the pregnancy test without help as her husband was also grieving their previous loss. She said, I wanted to test without my husband because I was excited to be having another baby, but I didn't know how he was going to feel because it was just a couple of months after we lost our previous one. However, Siobhan found that it was very difficult to take the test on her own because she was unable to find an accessible pregnancy test. She said, there's no blind accessible pregnancy test, which is weird to me. And I feel like it would be easy if you just do, 1 beep, 2 beeps, whatever, you would have it say pregnant. During her most recent pregnancy, Siobhan was diagnosed with gestational diabetes and had to access a diabetes clinic in a hospital where she again encountered several accessibility barriers. The first time she visited the clinic, she shared how difficult it was to navigate the environment. She said the staff were great, but the standard thing was, okay, go downstairs and get yourself a glucose meter and go home and test, and this and that, right? But I don't know how to find the pharmacy downstairs. I don't know how to get a glucose meter once I'm there. Once I get the glucose meter, I don't know how to read the instructions. I don't know how to test. This is all a new experience to me. Despite these challenges, Siobhan found the dietitian at the diabetes clinic to be a great help. The dietitian, she was fantastic. She said I could just email her the results on Excel. So I kept my own tables on Excel and sent it to her, and she actually did arrange that we just do phone calls unless I noticed a big problem. We could just do weekly or biweekly phone call. I didn't actually have to come in every week. And this accommodation was extremely helpful because it meant that Siobhan did not have to read or navigate the inaccessible diabetes clinic. So when asked what advice she would give to healthcare providers to make pregnancy care better for blind individuals, Siobhan said that a short time of teaching pays off. For example, she said that it would have been helpful if the healthcare staff at the diabetes clinic had taken the time to teach her how to test her own glucose levels and to do a practice run with her using the site-dependent test. These simple measures would have made her pregnancy care experience more accessible. So I hope that gives you a little understanding of practically how some of these challenges and facilitators came through. I just want to spend a couple of minutes providing an overview of the recommendations that we make in the report, and I think we'll get into these some more in the panel discussion as well. So we divide our recommendations into 4 categories: modifying healthcare system structures and processes, increasing service provider knowledge and resources, developing accessible patient supports, and strengthening the scientific evidence base. And I think all of these steps, it's important to really emphasize the importance of collaborating with and working equally with people with disabilities across all of these steps. So just to provide you some example of each of these categories of recommendations, in terms of modifying healthcare system structures and processes, we're really talking about these system level issues that need to be addressed, like the accessibility of pregnancy care spaces, resources, and related technology to the physical and communication and learning needs of people with disabilities. We need to consider how pregnancy care guidelines and physician remuneration policies can be adapted to allow more flexible care. So, for example, longer or more frequent visits if needed. And we'll hear a great example of this in Dr. Berndl's presentation, but we also need to think more about person-centered, multidisciplinary pregnancy care strategies that are available to people with disabilities and systems in place to coordinate this care. And all of this care needs to be delivered in a way that is affirming of people with disabilities. In terms of increasing service provider knowledge and resources, we recommend that all health and social service providers should receive a basic set of education and training about disability and accessibility related needs. This education should include information about ableism and the delivery of respectful care, clinical guidelines and other resources that address diverse disabilities in all pregnancy care spaces also need to be developed, and there is some work ongoing with recent guidelines from Dr. Berndl's group and others. People with disabilities also need to be actively involved in the creation of these resources and the delivery of training. At a patient-facing level, we also need to think about developing accessible patient resources. So developing more evidence-based resources to identify and address patient-identified needs for information. We need to ensure that routine pregnancy-related education, such as breastfeeding and newborn care clinics, are accessible to people with disabilities and address their needs. And we also need to support community organizations through more funding to provide resources to people with disabilities who are planning a pregnancy or who are new parents. And then finally, on the data level, I think the research that we've done certainly contributes to the evidence base that is needed to do many of these policy and practice changes, but there still is a need for more work. And this requires routine inclusion of disability-related indicators in different data sources that can be used to monitor population-level trends and outcomes among people with disabilities and other groups. We also need to create outcome and experience measures related to patient care to ensure that our efforts meet the needs of people with disabilities. And I think all of this requires a national funding strategy developed to support research on disability and health equity. So bringing all of this together, I think there's a lot to be taken from this, and I'm looking forward to hearing from the panel and Dr. Bernal's presentation on their thoughts. But I think really the conclusion that we make in this report, and that we would like to come from our time here together, is that, you know, these data show that it really is time for action, where we bring policy and practice leaders together with people with disabilities to use this and other data to make pregnancy care inclusive of and equitable for all people with disabilities. And so with that, I will turn it over to Dr. Berndal to introduce herself and to tell us more about the Accessible Pregnancy Care Clinic as an example of how to do this work well. So thank you very much, and I'm looking forward to hearing from Dr. Berndal.
Well, thank you so much. I'm just going to put this on. There we go. Let's hope that works a little better.
And we're still getting a bit of a
feedback there.
If you
Is
can
that
just
better?
mute.
Is it better now?
No.
I put myself on mute.
Just, are you able to mute the laptop?
You know, I'm just going to hang up on this end, and then I'll redial in.
Sounds
I'll
good.
just do the presentation. Okay. Okay. Are you able to hear me at this point?
Perfect. That's
all right,
great.
So I'm just going to share my screen so I can give you a little presentation about what I do. I'm Ann Berndal. Thank you so much for the lovely introduction. I'm the director of the Accessible Care Pregnancy Clinic, and I'm a maternal fetal medicine specialist at Sunnybrook. And I'm really excited to talk to you today about what I do and the clinical care that we provide for people with physical disabilities. So the Accessible Care Pregnancy Clinic at Sunnybrook, we've been providing accessible care to hundreds of people since 2017, which is when we started. And when we developed this clinic, we did it in a person-centered manner. So we did interviews with people who had recently had babies, who had disabilities. We spoke with different community leaders. We tried to get as much information as we could to really make sure that we were planning things in a way that was inclusive of the people that we were trying to care for, and that we were doing it in an appropriate manner. After we got all that information, we launched our clinic, and we're doing this because we know that more people with disabilities are giving birth. We have lots of data that this is happening more and more frequently. And there's so many barriers to care that we learned from these interviews that we're doing and from the past data that's there. So what we do at our clinic is we provide preconception counseling, which I think is really, really important. We provide pregnancy care, birth care, and postpartum care. And we do this in a welcoming environment and a accessible environment. I'm just going to flip this over. So who do we care for? We care for lots of people with lots of different types of disabilities. And this is a slide that I really love because these are a lot of past patients that are kind enough to share their stories, share their pictures of their beautiful families. And all of them have a different reason why they needed to come to the clinic. All of them have a different reason why they have a physical disability. And that disability impacts them both before pregnancy, during pregnancy, and afterwards differently. So we really need to be focused on individual care. So some of the reasons why people might come to see us, we have people with, for example, spinal cord injuries, people with myasthenia gravis, people with cerebral palsy. We have people who have been in trauma. So we see a lot of people who've been in car accidents, chronic pain, other developmental conditions. So we see a lot of variety of individuals. And really the thing that's so interesting and wonderful, I think, about providing this care and getting to work in this clinic is learning about each person's individual needs and then providing a pregnancy and birth plan for those people on an individual basis. So the way that we do this really is quite multifaceted. We try to address barriers to care on many, many levels. So one of the first barriers to care that we often see and people often talk about is, do you have an accessible space? And we do have an accessible space. We needed to make modifications when we started the clinic. We had to write some letters. We had to look at some building codes, but we do have an accessible space. And we're really fortunate in that we also have an accessible birthing suite and an accessible ultrasound room. So at the top corner, you can see an image of our accessible ultrasound room. That room also now has a ceiling lift as well. It's big enough for a Hoyer lift. You can get a power chair in there. And we did a study where we were looking at how can we improve the way that we provide ultrasound for people with disabilities. And from that, we learned about changing our booking times for when people were coming in, being pre-prepared with equipment, and having the same sonographer provide the ultrasound for that person every time they came in. And this way, we're providing really high quality fetal ultrasound. So we're doing a good job with all of our diagnostics in an environment that's really comfortable and safe for that person, not feeling rushed and feeling really, really respected at the same time. We have a scale that is accessible. The way that we usually do our weights is maybe on the first visit, if the person is transferred from their wheelchair to do their ultrasound, for example, sometimes there's a transvaginal scan component of it. We take that opportunity to weigh that person's wheelchair, and then we just document that. And then when they come in subsequent visits, we can just weigh the person in the chair, and then we can subtract the values and know that we're tracking weights appropriately for that person. You can see in the bottom left corner there, that's our accessible birthing suite. It's a big room. It's a beautiful room. It's very, very sunny. And again, there's lots of space in there for support people, for whatever equipment you might need for that person. And it also has an accessible washroom with a wheel-in shower. So it's a really good space for people who need equipment during birth or in the postpartum period. One of the things that I really like about what we do is we have a really great set of lactation consultants who are really keen on providing care to people with physical disabilities to help people be prepared for feeding their baby after birth. And often what we'll do is we'll get our patients to meet with the lactation consultants before they deliver. And people will practice with weighted dolls, for example. Sometimes someone might have one-sided weakness. Sometimes someone might know that they're needing to feed in a wheelchair most of the time. Sometimes someone might have spasticity. And then the lactation consultants can work with them to find a way that's really comfortable to hold the baby so that when they do give birth and they're feeding their baby, they've already practiced and they have some confidence with what they're going to do. Another big piece of this is having really individualized feeding plans. So although many people may be choosing to breastfeed and wish to breastfeed as much as possible, there might be scenarios where it doesn't make sense for that person to be doing it all of the time. So for example, if we know that someone has myasthenia gravis and they're at risk of relapse if they're not getting a full night's sleep every night, then they might come up with a feeding plan where they're providing breast milk through breastfeeding during the day. They're doing some pumping, and then a partner or support person is going to feed the baby at night to allow that person to rest, to decrease the chance of that person having a relapse. So really it's about individual care planning for what's going to work for that person. Something else that I really like, and this was a big policy change that we had in our hospital, you can see in the lower right-hand corner there. This is an individual who needed to have a cesarean birth for her delivery, and she had quite a number of medical complications during her pregnancy. And there she is getting ready, and she needed a general anesthesia. So that was the right thing for that person. And when she's going into the operating room, you can see the people with the blue scrubs on, those are the anesthetists and one of the nurses. And the person with the white jumpsuit on, that's her partner. And so we bring the partner into the operating room with us, even for a general anesthesia. And this is so that not only are we providing really good family-centered care, although it's always scary to go into the operating room, we try to still keep this as a celebratory environment. This is still a birthday party. It's still a family event. And that partner tends to know that person's body really, really well. And we can help make sure that person is positioned in a way that's really comfortable and safe for them. And that partner can help ensure that we're doing that. So sometimes we need to use, for example, special padding, pillows, things like this. Everyone's body is so unique, and we really need to respect that when someone's on an operating table. And this is a way that we keep people feeling really comfortable and safe, even when we have to, for example, do a cesarean section under a general anesthetic. And one of the things that, sorry, I'll just flip this back here. that really is the the key of all of the care planning that we do is the amount of teamwork that we have available. So I love this image. We have this person who's had their lovely baby at the center of it, and then surrounding all of them is this wonderful care team that we really come together and communicate really well with one another. And everybody's care team is going to be different. So myself, I'm the maternal fetal medicine doctor, so I see them during the pregnancy and provide that pregnancy care, but also coordinate a team. And this can include a pain physician, an anesthetist, a hematologist, a respirologist, a neurologist, a neurosurgeon. So we all get together and work together to make sure that we have a comprehensive care plan. And for people whose care plans are more complex, then we'll usually have a team meeting that involves the person and their support person. So we can talk about, what's our plan A. So in our, ideal scenario that everything's planned out, but we also know when it comes to birth, there's always surprises. So what's our plan B if something's happening in the middle of the night, if something is not what we initially anticipated as to what would be happening during birth, what are we going to do? And so we all work together to make sure we understand what's going to happen in these different scenarios. So what have we achieved so far through this clinic, as well as seeing many people and helping them throughout their pregnancy. We've also published guidelines through the Spina Bifida Association, through the SOGC, looking at labor and birth and postpartum care for people with disabilities. And we've also published a toolkit as well through the Provincial Council of Maternal and Child Health. And I just got a message from you. There we go. The other thing that I'm really proud of is that we've been recognized by the Accessibility for Ontarians with Disabilities Act as a model of inclusive and specialized pregnancy care. And so this is something that, as a team, we're all very proud of, and we're hoping there'll be more accessible care clinics and people also following this model of care in other centers. So, in the end, pregnancy care for people with disabilities will be even more accessible. We've made many changes within our hospital from a policy level. Some of these are really quite easy once you realize that these are beneficial changes. So this includes our ultrasound flow, support people in the operating room. There are some individuals that, for safety reasons, we might need to extubate them in the ICU, for example. That's the safest thing for that person. But we bring the baby down so they can do breastfeeding in the ICU. So we try to keep that family-centered care regardless of what the health and safety needs for that person are. And in the end, I feel that we've really created a place of excellence, a place of respect and care for a population that we know in the past has not had a coordinated care and has been really neglected in terms of having comprehensive care from a pregnancy and birth perspective. So this is one of our lovely repeat customers who's come back more than once, and I've been so fortunate to care for her during both of her pregnancies. This is an individual with a spinal cord injury who really appreciated the care that we provided at Sunnybrook and was quite public about her gratitude for it, and so I do appreciate that. And if anyone here has any questions, is interested in helping to provide this kind of care, is interested in how we develop this type of care, my email address is there at the end. And there's also a link to our webpage to get in contact. So thank you so much.
Thank you, Anne. We'll now pass it on to Yona Lunsky. Yona, can you hear me? Oh, there we go. I can see Yona. I can't hear you yet. Okay, we're having a little technical difficulty. Oh, no, we're not. We are here. Yeah, you're still showing as muted. You're not able to unmute. Okay.
Misty, while you're sorting that out, I can act as
Thank you.
moderator. So thank you everyone for your patience with technical difficulties, the joy of doing these things remotely. I'm really pleased to be able to open this up for panel discussion. We have a number of panelists with us who are members of our advisory committee. So I'll turn it over to them to introduce themselves. Perhaps we can start with Melanie, if you'd like to go ahead and introduce yourself.
Good afternoon, everyone. My name is Melanie Basso, and I am calling in on the land of the Coast Salish peoples of the Musqueam, Squamish, and Tsleil-Waututh nations, colonially known here as Vancouver, British Columbia. My role is I'm the senior practice leader here at BC Women's Hospital, and I have the privilege of working with families who require planning ahead of their birth, and have worked with many families with disabilities in my role as senior practice leader here.
Thank you, Melanie. And Wendy, would you like to introduce yourself?
Sure. Good afternoon, everybody. My name is Wendy Porch, and I am the Executive Director at the Centre for Independent Living in Toronto, also known as CILT. I use she, her pronouns. I was born with my disability, which is a limb difference, and I am therefore also a mom with a disability. The Centre for Independent Living in Toronto is a community-based resource centre by disabled people for disabled people. And we believe that disabled people are the experts in what they need. And we work to try to develop services and programs that enable disabled people to be empowered, to live with dignity, and to have choice and control. We're one of the only organizations I know of that has a Parenting with a Disability Network program too. So I'll talk a little bit about that later.
Thanks so much, Wendy. And Lori, if you'd like to introduce yourself.
Yeah, I don't know. Hopefully you can hear me all right. All right, sounds good, because I can't see myself. But yeah, so my pronouns are she, her. I have wavy shoulder length hair, white skin, and I'm wearing a white cardigan with a blue striped shirt. So, I mean, I live with a disability myself. I was diagnosed with a chronic illness at the age of 14. I'm a mother to 2 children, so I can relate much to what Minu was saying at the beginning in terms of her pregnancy journey. And I was involved as well here as a peer researcher for the duration of the project, along with Kate Welsh. So I bring my lived experience of pregnancy to this, amongst other projects, in terms of my role as well with the Canadian Arthritis Patient Alliance as well, where I've done a lot of work to support people with arthritis during pregnancy and into parenting. So similar to Wendy, but a little more specific to arthritis, and that we're just trying to provide the resources so people feel equipped and prepared to take on this role, right? And so anyways, it's nice to meet you all.
Thanks, Lori. And our fourth panelist is Dr. Berndl, who you've heard from already. So we're going to launch into some questions for the panel. Panelists, please answer as you see fit. So one of the things that the study that we've all been involved in has really tried to talk about is the important changes that we need to make to the pregnancy care system to make it better for people with disabilities. So I'm wondering, from your perspectives, what's the single most important change we can make to the pregnancy care system at a policy level, at a clinical practice level, to make care better? Whoever would like to respond first.
Maybe I'll start. You know, one of the things I think that is critical, and if there's one change to be made, which is, I think, the question, I think there's a lot of changes to be made, but if there's one to be made For me, it is overwhelmingly in the training of healthcare providers to recognize and to be able to support disabled parents and parents to be as a whole. So I think, one of the things that we experience as disabled people is this idea that we are not sexual. So therefore, we're not ever going to have kids. That's just not going to happen. And that is still something I think that many people are encountering. Training for healthcare professionals, I think, has to be, overhauled in this regard. We have to be able to acknowledge that disabled people do have sex. We do require sexual and reproductive health care. And that, as parents, we want to be the best parents that we can be too. But we need you to be knowledgeable as well. So throughout my pregnancy journey, everywhere I went, and I'm not shy, you can imagine, everywhere I went, the healthcare providers that I spoke to said, well, yeah, I can see that you're having questions about how you're going to hold your baby when the baby gets here and how you're going to feed him. But, you're the first one we've ever had. You're the very first disabled person we've ever seen, so we don't really know what to do with you. So we'll try to help you, but we're not really sure. So for me, the recommendations, Hilary, out of the report around training, the broad and specific recommendations are the change that I would make in the system to start with.
Thanks, Wendy. Go ahead, Lori.
Yeah, no, I mean, just sort of building on that. I mean, I think that's a very important point as well. But I mean, it's lovely to see examples like, Dr. Ann Bernadotte's clinic, right, in terms of accessible pregnancy care spaces. But, I think it's important to look at this very broadly in terms of how people access the healthcare that they need, as well as the other supports that they may need. I know I had difficulty even participating because, and let me first say that I have an episodic disability, so it really went up and down, and it was very, sort of not as stable during my pregnancies because of the many medication changes I had to make in the lack of data around. But so I needed, some of those supports more actively offered, for example, so I can even access some of those things, accessing things like, those sort of prenatal, training and that on my own was more difficult because it wasn't available in a space that was easy for access. So as well as just managing care amongst so many different providers, every time I'd ask, and it's not to say, the medical model is very specialized. So I might ask my maternal fetal medicine specialist for advice about my core condition, right, which is rheumatoid arthritis. And they'd be like, well, talk to that person, talk to your rheumatologist. And it's just a lot, right? And as Minu said at the beginning, this is supposed to be a happy time, but I felt it to be a very stressful time because of all these different things sort of layering on top of each other. So medications, accessible spaces, just getting to know what my life would be like as a parent, living with a disability that went up and down, and then just the care itself being difficult to navigate at times. So that would be my one thing, which is a very big thing, I realize.
Yeah, no, great answer. Thanks, Lori.
I can speak about from a I think the most important thing about the report and what it does is it rips the Band-Aid off and says, here, this problem is here. And it's here in bigger numbers than I think anybody was prepared to see. And so, we talk about pregnancy and disability as a small amount of patients, but it's actually in Ontario a very large number. And I'm coming from British Columbia. So I think how we address this from a policy level is, first of all, we need to have accessible providers' offices, birthing settings. Dr. Brindle's example is a lovely way to set the setting, but all the places across Canada don't have that. And so we need to expand that. We need to have policy changes at the healthcare level, at the system level, at the provincial level, at the federal level, so that these changes can be mandated to allow people to access care appropriately. I think even having access to things like the cot is meant to stand up and pick your baby up. And so we have an overbed cot that opens at the front. And so it then can sit over the bed and it can open from the front because not always can people stand up to pick up their baby. I think at an institutional level, we need to have welcoming messages, and we have so that patients can recognize themselves and feel welcome. Photographs of on the wall, some of those lovely photos that Dr. Berndl showed should be on the wall so that people feel welcome. And so the spaces and the equipment is easily known how to use by all staff so that people aren't fumbling around and going, oh, I don't know how to use this equipment. That makes people feel very nervous, would make me feel very nervous. And I think from a policy level, as we're writing documents, which we've done a lot of, we have to involve people with lived experience so that we can get it right and it's not just an academic exercise. I think from a clinical practice perspective, we've talked about regular education and regular education. So we've been presenting to nursing students at the nursing schools to embed this into the curriculum. And I'm not sure where the medical curriculum is at, but I think it's badly needed so that we're not just educating part of the healthcare team, that all healthcare team members are getting this information. And then for patients, I think starting with that preconception assessment is really important to understand any underlying health concerns so that you're not already pregnant by the time we're trying to sort out, the best care, and having a plan right from the beginning, even before the pregnancy starts, about where is the best location for delivery for you, where is the best resources and supports, and then what kind of impact is that going to have on you to be able to access care in that area. So thanks
Melanie. And Anne, over to you. Single most important change. Oh, we can't hear you. You want to unmute? See if that'll work. So maybe what we'll do while you're figuring that piece out, Anne, we'll see if you can either write in your response or if the sound will work in a moment. And I'm going to bring up the next question. Okay. We've heard about many barriers to pregnancy care, and we've actually heard some examples already. So thank you for those. Here's the question. If you wanted to make some of the changes you've suggested, how do we start by addressing these barriers, right? So think of a barrier to change and tell us what we can do about it. Who wants to go first?
So again, maybe I'll just start. One of the barriers for me that I think is significant that we haven't really called out very specifically is that there is no AODA healthcare standard yet. And so when we're talking just about healthcare spaces, there is no requirement really for those healthcare spaces to be at the core accessible. And so, I mean, it's ironic. It's always ironic to me because I think there is a kind of general understanding that disabled people might have more time spent in healthcare spaces. And yet the sort of the structure, the underlying requirement that those spaces are accessible isn't there. And I think, when we're talking about the provision of, in this case, care around pregnancy, I loved hearing about the clinic, your clinic, Anne, at Sunnybrook. And I know that we've connected with you through our Parenting with a Disability Network, and the brilliant work that you're doing there. I think that those kinds of spaces should be available to people across the province. I think that disabled people should be able to choose their healthcare providers in the same way that everybody else does, particularly when it's something as important as your pre and post pregnancy care. And so without a healthcare standard around the AODA, we're still not quite there. We still don't have that kind of baseline upon which we need to build, because frankly, that standard is still just going to be the start, right? We need to do better than that, but we don't have the formal requirement even yet. So we need to get on that.
Thanks, Wendy. And relevant also for folks from other provinces who maybe don't have the legislation yet either. So, but let's start with Ontario. Okay, how about others, Melanie or Lori? Or we're just getting Anne's sound to work.
Yeah, I apologize.
Oh, we can hear you. Go
I've
ahead.
been so challenging. I think I've missed a little piece in the middle, so I apologize if I'm repeating what people have said. But I just wanted to respond to all of the lovely things that I've been hearing so far, and echo the need for that. So Melanie, I think one of the biggest things that you brought up that's important is the education piece for all healthcare providers and anyone that's going to come in contact with someone with a disability who's coming into care and is having a baby. From on the medical end, like from a physician perspective, because that's the group that I spend most of my time with. The thing that I've seen that has been the most enthusiasm building for me is a number of people who want to come to the clinic specifically to get experience. And people do want to become better at providing care for people with disabilities during pregnancy. We get lots of requests for it. We actually did a nice study looking at program directors across the country, desires from residents in the obstetrics and gynecology program, and there's a lot of enthusiasm. So all these things always take so much time to build and develop, but I think that this next wave, this new generation of OB-GYNs, I have a lot of hope for them. So I'm hoping that this will continue, and I'm hoping that this will become part of our standard education that's available, so that people do have some education in the background when they're starting their obstetrical career, so that it's not just here that you can come, or just in BC and Vancouver where Melanie is, that you can go to get this type of care, that there's people in other centers that not only feel comfortable, which I think is a really key aspect. So if someone hasn't seen, let's say, a specific condition or something before, that person feels apprehensive, and then it makes the whole thing very unpleasant, I think, for the person coming and trying to get pregnancy care. But they can also then become advocates for the type of changes that you need in a hospital-based setting, in terms of timing for visits, equipment, getting in and out of rooms, washrooms, like all of the stuff that's just going to make a really pleasant and accessible visit, and a well-informed visit. So I think that's a really good piece from the education perspective. I think it's not there, but I think it's key, and I am enthusiastic about that. Wendy, you were mentioning just about the preconception component. And one of the things that that I'm very hopeful of is that people, not just OBs, by the time they get to me, they're usually already pregnant. We're trying more and more to have people being available to come and see us beforehand, so we can really talk about what pregnancy is going to look like. But I think that there's more interdisciplinary care that's happening, and I'm seeing this on a very small local level, where neurologists and the rheumatologists, the pain physicians, they know that there is an accessible care clinic here. They know that it's important to get that preconception counseling. And I think that people are starting to talk to those care providers as well, that they might be seeing even more frequently than anybody else, if that's their touchstone person, to start talking about this. So it's not just like the OB-GYN or family medicine or midwifery group that's going to be seeing people in pregnancy, but it's that preparation beforehand from the other healthcare providers, so that everyone's feeling comfortable going in. So many people have said so many smart and wonderful things here. So I'm always so glad to meet people who care about the same things I do. So I'm glad to chat about them.
Thanks, Anne. Any other thoughts, Melanie?
Yes, I think one of the things that we've tried to do is develop some education for providers. And so we do have a free online course on our Provincial Health Services Authority Learning Hub. It's called Caring for Pregnant and New Parents with Physical Disabilities, and it is a free online course that is available for providers that can go on. And we've had people reach out to us to say that they've taken the course and have learned a lot. So it doesn't give you hands-on experience, but it gives you some background knowledge and at least where to start. And sometimes it's about knowing what questions to ask. And so so we have developed that. I think the other barrier that I see is in working with birthing people and families with disabilities is that we do all this planning and for the pregnancy and for the labor and for the birth and then the postpartum period until they go home. And then a lot of the resources just kind of drop off. And so it's okay, done, on to the, and I feel like there's a gap in that transition of, like, pregnancy care is high touch, frequent visits and whatnot. And then after, when you really need support and help and breastfeeding and a new baby and sleep deprivation and all the stuff that everybody with a new baby feels, the supports and the resources are less, and the recognition of that. And that can affect mental health, it can affect physical health, and it can affect your relationship with your baby. So if I had a magic wand and I could fix the world, I would make that transition much more smooth, to allow parents who are transitioning home with a new baby to have much stronger supports.
Thanks,
Yeah.
Mandy.
Yeah, and I think my point really builds on that, and actually what the two panelists here have mentioned is around, I spend a lot of my time asking organizations or researchers or governments or policymakers to write the communities they're serving into much of the work they do, and to recognize that there's just like a lot of knowledge there, there's a lot of support. And often, like, I mean, Wendy's talking about some of the work that's done at SILT. We've done some with the Canadian Arthritis Patient Alliance. Like, we're trying to address these gaps so we can try to, and it sort of fits in within a broader society, right? It's not just necessarily what happens in a hospital. People go home and they learn to be independent parents all by themselves, right? And we should be supporting that. And they just need some support to be able to do that. And so I just think it's important to involve disabled people in developing some of these solutions. So you crowdsource from a broader base of knowledge as well from others who have tread the same path and learned some of these lessons the hard way. So.
Thanks, Lori. There's I think sometimes people don't do stuff because it just feels too hard to start. And I think there are so many practical examples we've already heard. Don't be afraid, do something. And there are things to do, there are people to look at, and get it done early, right? And then keep it going, whether it's about our training or actually about making sure that people who are disabled have that time, for that planning early in their process. I'm excited. I can see you're excited. This is an exciting time around improving accessibility. We've got our data now. We've got, like you say, we've got this report, right? We're going somewhere. Question is, what excites you the most? So I know you've said some of those things already, but if there's something you haven't said about what excites you the most that we can build upon going forward.
I can start because I'm super excited. We have a brand new publication called Motherhood After Spinal Cord Injury, Breastfeeding, Autonomic Dysreflexia, and Psychosocial Health. So we have clinical practice guidelines that are published, and we also have a patient guide called Breastfeeding Following Spinal Cord Injury, Consensus Guide for Mothers. And so this is a consumer guide, and it talks about breastfeeding. It talks about the impacts of breastfeeding, and also on the potential impacts on some patients with, or some parents with spinal cord injury, on their physical health. And that, we've discovered that, autonomic dysreflexia can happen. And so breastfeeding can't always happen safely for some families. And I think in my career, I've seen families kind of set up, of course you can breastfeed, there's no problem. And, and I think that's been, had quite devastating effects on people who are already feeling, like they're a new mother and now they're struggling, and everybody says everything should be fine and it's not fine. And so I think I'm super excited about these publications, both for clinical practitioners, but also for families.
So who else wants to share their excitement? And then we're going to turn a little bit to some of the great questions in the Q&A.
I'm super excited.
Oh, no, you go ahead.
Sorry,
You
go ahead.
No, you go ahead.
I just want to say, I'm really excited about this report and about all of the people that are here talking about this today, about the kind of interest that this topic is generating. Because when I was pregnant 12 years ago, there was nothing. There was really nobody talking about this. There was there was a lack of knowledge across the board. I honestly, as I said, they told me I was the first one. I felt like the first one. I know I wasn't, but I felt like the first one, you know, and now we have this network of all of you. We have this amazing paper that has some very concrete recommendations. I'm excited because it feels to me like there is going to be change. And I have thought since I came through my own parenting journey, and, you know, at the end of the day, in case you're wondering how I held my baby with one hand in the first 3 months, I didn't. My husband's work had passed a exceptional parenting leave policy that he qualified for. And so he was home with me for the first 4 months and picked my baby up and handed him to me, actually just put him on the breastfeeding pillow and then took him away and burped him for the first 4 months until, you know, his neck, my son's neck sort of firmed up. But what I'm trying to say is now we have all of this knowledge. We have all of you who are interested. We've got talking, we've got resources, we've got ideas about training. I don't think that there's going to be another parent, hopefully, at least not in Toronto, that comes up against these same kinds of barriers and feels like they're alone. And I think that's down to all of the work that everybody's done. So I'm excited about those changes.
Thanks, Wendy. How about you, Anne? What are you most excited about?
I have two things. Well, first, I just wanted to send out a thank you to Wendy, because we've sent many people that we've met through our clinic to the Parenting with a Disability group. And it's been a really great resource and so much wonderful feedback. And it's wonderful because as Melanie was saying, that's the real gap. And I feel it. I'm an obstetrician. This is where my knowledge base and what I can do to help people and how I can participate in this, that's where my skill set is. But so I'm not as skilled in that area, but I see it there and I talk to people about it. So I'm so grateful to have the resources that you have available. And I hope that we continue to work closely together so that we can just be like in tandem and like keep it going. And I think it's really, really awesome. So first of all, just wanted to thank you for that. The other thing that I'm excited about that's coming out also from like a research perspective that is similar to what Melanie's doing, and Melanie, we have to get together and talk about this stuff because I think we're all on the same track, is we're just getting a lot of analysis of, we just did a big spinal cord injury and urogenital health project. And so we have 780 people with spinal cord injuries assigned female at birth, and tons of birth data, tons of breastfeeding data, tons of information about interpersonal violence, information about contraception information, autonomic dysreflexia, comorbidities, what happened during birth, pushing positions. Like, it's a massive, massive study. And we're just getting so much information about it. And what you're saying about breastfeeding and spinal cord injury, we have so much interesting information. And what you're saying about helping people set up to do well and knowing what is going to work for them and the variety of outcomes that can be there, and they're okay and they're good parents and they're feeding their baby and you're not a failure and you've done a great job. I'm so excited about this information getting out there, and I'm hoping maybe, Melanie, since we have very similar interests and overlap, and that knowledge translation piece is so important, that would be great. So I'm excited about always meeting people at this type of event that also care about the same sort of things. It's a bit of a niche area, I find, sometimes in research, so I'm really excited, and I'm glad that we're going to start publishing really condition-specific data. And I think that if we really want to move forward in terms of people with disabilities having access to evidence-based care, which is what quality care is, not lumping everyone together in one big group, but saying this is what we should expect for you and how we would manage you as an individual. We really need to have this condition-specific information. Otherwise, we're not going to be able to move forward clinically in terms of improving those outcomes and providing that high-quality care. So the more I hear about those condition-specific studies that are being done, people participating in them, and there's been so much enthusiasm, I think that's how we're going to really move forward in terms of having really good quality of care for people. So that's what I'm excited about.
Thanks, Anne. And Lori, how about you? And then we'll get to some of the Q&A.
Yeah, no, really just, it really excited. This has been, like, I've been involved in, working with you, Yona, and Hillary. It's hard to believe for 7 years, right? And it's something that, much inspired, similar to Wendy, I had my last child 11 years ago, right? And I really hoped that I wouldn't see anyone else experience some of the, serious outcomes. Like, we both ended up in intensive care, and, really hoping that that won't happen to others. But I do feel really hopeful now that that won't be the case, right? That we'll be leveraging all this excellent work and continuing to partner and collaborate going forward, right? To see some real impact for people with disabilities or specific patient communities out there. So hopeful that hopefully we can carry things forward right to implementation and impact.
Thanks, Lori. I think it's a reminder for all of us, right? Like, there is something each of us can already do, and it's not one person's job to do it, right? There's things that we can all contribute to. And you talked about some of the more specific stuff that we need, that we shouldn't just lump all people in the same category. And we also can't lump all people with disabilities in the same category.
Absolutely.
And I saw a few questions. We saw some really nice examples, and folks shared, Leslie shared from our team, some of the resources that Melanie was talking about in terms of the online training for the spinal cord injury and pregnancy. But there were a few questions that came up around folks who have intellectual or developmental disabilities. One question was kind of about, from Sabrina, about how to identify if someone has an intellectual or developmental disability. How would we know if some of those things are going on? What kinds of questions might we ask? And then there was another question that came up a little bit earlier, also about sort of supporting that group. And we've talked about them a bit less. We've talked more about some of the visible disabilities, although Laura, you talked a bit about your own episodic kind of disability. But what do you think about some of those disabilities we've done a bit less work on?
So, I mean, those ones can be more challenging because I think there's, first of all, a ton of stigma. I mean, there's a stigma around all types of disabilities. So, and that person may not wish to disclose to their healthcare team right away if they don't have a sense of trust that's there. So they might be not wishing to reveal it because of fear of stigma and bias. They don't want to feel judged. They, don't want someone to make presumptions about who they are as a person. If they do have a cognitive disability, they want to just be cared for and respected. Sometimes, if you can read a bit about a health history in the past, it can give you an idea going in terms of questions that you can ask. I think there's a lot of ways that you can phrase things in a really respectful and kind and open manner. You can say things like, is there a way that you prefer I communicate with you? You can say, do you prefer to have a support person with you? You can encourage that support person to be with them as much or as little as they wish, because sometimes that support person, they're like, I want you out of the room when I talk about this one particular thing with my doctor. So, just really clarifying, the role of that support person and how much they're there. I think it's always good to check in about how they feel about what you just said. So you can explain something and then make sure that there's lots of space for questions, and then gauging where the questions are at in terms of how you can better support that person. A lot of it, I think, is building a trust that person can talk to you about their specific needs and providing a really good space for that. Sometimes I ask really specific stuff like, is there something in the hospital environment that you find really triggering for you or really stressful? Some people find hospitals terrible. You go in and it's different, it's cold, it's scary, it's bland, you're not near anything that you're used to. And so I'll say things like, is there something in particular? Some people, it's a needle phobia. They're very, very strong for some individuals. Sometimes it's the way the door is positioned can be very frightening, if the door is open or closed. So, there's things that you can ask specifically. And I think as in with any person, but especially any person with a disability, that person knows themselves best. And if you provide an open space to, and genuine concern for that person's well-being, and that you're trying hard to accommodate and be open to it as much as possible, people will let you know how you can help and support that person best.
Yeah, can I just add something too, because I think it's along those lines as well. And for me, as a person with a disability, I was telling people what I knew were going to be the barriers that I was going to experience, and people were sort of like, "Well, are you sure? Are you sure that's going to be a problem? Sure. It's probably going to be don't worry so much about it. So much along the lines of what you're saying, you know, people with developmental disabilities have also arrived at that point in their life, right? So you have to presume that people have the capacity to tell you what they think the issues are going to be and the kinds of resources and supports that they need, right? And as you said, it's very much in the relationship that you build too. You know, as a disabled person, I can tell when somebody has weird feelings about me because I have a disability, right? I know, I can tell, and people with developmental disabilities can do that too. And so really it's about, like, you know, how you approach those conversations and acknowledging and understanding that people are still the expert in their experience and their needs. You come with specialized knowledge, but the individual is the person that you should be really turning to say, what do you think the issues are going to be? And, you know, what are you concerned about? And how would you normally manage this, right? Like, what do you need in that conversation?
One thing I'd like to add, I work with a really phenomenal advanced practice nurse named Elizabeth Young, who is really good at everything she does. And one of the things that we try to do if we know that we have a person coming to our clinic who has a disability is she'll call them or get in touch with them before the first visit and do sort of an intake phone call that really talks about that person's needs during the visit and what we can do to make it a more comfortable visit. So everyone is prepared, but also that person knows that we care about how that visit is going to go for them. And a lot of the questions that are asked, and she's so good at phrasing them and asking them in such a kind and open way, are things like, you know, how does this disability impact you? You know, how does that, not just, oh, you have this diagnosis, spinal cord injury, or you have this diagnosis, it's how does that impact you, you know, on a day-to-day basis? You know, how does that impact you from a communication perspective? And so we try to get that sense of it even before we start. And then it's, I think, lays the ground for a very open communication. And the person knows that we do truly wish to do our best, and we're not perfect. You know, we're going to make mistakes, we're going to do it wrong, or but as long as we keep that communication open, that they know they can tell us, and that they're not feeling apprehensive about telling us if there's a concern that we're not addressing, that we can really move forward in a positive way. So that pre-phone call, I think, is a really helpful starting point.
Such great ideas. You know, we're not talking about very complicated things. I mean, I'm sure there are some very complicated things we could also talk about, but so much of what I think is in the report and really in your comments today are about respecting people, looking to people for their expertise, you know, relationships. Like this isn't a one-shot visit, right? It's a relationship, it's a journey, and we have to make connections with people early and keep them and trust that they know, I think, so much of what they need, right? I'm just looking, there's a couple of resources and things that people have put in the chat, and I just want to say we have recorded this session, bumps and all, but we'll be able to watch that after. When we send out the recording, we'll also send out some of these great links. There wasn't just stuff about Ontario and BC, but also a really nice resource with some related things coming from the UK, and people might have other ideas of resources as well. So we'll make sure we share that information with people. Thank you. There were a few questions also about some of the research pieces. So what are we looking around data around race and ethnicity? And also, how did we do that qualitative work? And I don't want to look at the panelists for that. I think that's more of a piece for Hillary and I. I don't know, Hillary, if you wanted to comment on any of that, and then maybe we'll wrap things up.
Absolutely. Thank you. I've loved listening to this panel presentation. This is just so exciting. In terms of the research pieces, so unfortunately, with the way that health administrative data in Ontario are collected, we don't have any information on race and ethnicity. So that really stops us from looking at, you know, the combined effects of racism and ableism on some of these outcomes. I think hopefully that's something that will change going forward as we start to acknowledge the importance of collecting equity-based identifiers in health records, but so far that's still sort of a gap in our work. In terms of the qualitative studies, again, you know, I think there needs to be more work done on the intersections of these different forms of oppression on people's experiences. With our interviews, we did have some diversity, but by and large, most participants we're white, we're fairly, highly educated and came from, middle to upper class socioeconomic status backgrounds. So when we hear all these stories of barriers, I think it's important to remember that those barriers and challenges are even greater in some population subgroups. So that needs attention as well. So still some, questions that remain unanswered, some voices that need to be heard, but hopefully this is a start in getting those conversations going.
Thanks, Hillary. Okay. So I'm not seeing any additional questions in the chat box. I don't know if there are any final words from the panelists. If not, I'm going to do a little bit of a wrap up to bring things together.
Well, I think that one of the most important things that maybe we all know, and talk about is resources for parents, and having, resources written, easily found, with health literacy at the right level, so that it's not, so medical jargon. And so we have to have these resources available where people are looking. And so that's why we need to work with our families to say, where are the best places? Because our website or your website, people might not look there. So we have to make sure that those resources are up to date, and can send people to the right places. Because that, probably when Wendy and Lori were having your babies, there wasn't a lot of information available. And so just mentioning the importance of that.
Thanks, Melanie. I'm thinking about Minu's comments at the start, and how, 20 years ago plus, the experience that she had. But then we hear stories that aren't hugely different from Wendy and Lori, about 10 years later. We don't want to be in the same place right now, and we certainly don't want to be in the same place 10 years from now. But I do feel optimistic. I think that there's a lot of information that we have. We have people listening to this from different parts of Canada, but also in the US and the UK. And I think we have to find ways to share our information, really everywhere. Like, you make a resource, it's useful. It's probably useful for other people too. We can make this easier for lots of people by being able to use technology to exchange information, and pushing the envelope and saying it's time. It's really time, because we know how important this is and how well things can go when we do things right. I've learned so much from this, Hillary. I know you've just been a fabulous leader bringing all of this together, and everyone together. I think what's made the project so great is that it really has been a relationship-based, long project where we just kept figuring it out and working things out and combining. I saw a comment here about the qualitative interview methodology and how that works. We couldn't do the numbers alone. They do tell us something very important that we can use, but we have to combine that with what people are experiencing. And I think that's hopefully the power of the report that we have as now, and also where things will keep going moving forward. So I just want to say thank you to everybody on our panel for participating, for all of you listening and adding in your resources and your great questions, and the folks at ICS for putting this panel and everything together, and of course, Hillary, for your leadership of the project. So share the report, people. There's lots of different ways, different versions of the report, different resources. Let's keep it going. Let's use this momentum and excitement, and let's see the change we want to see happen. Thank you for taking part.